Good afternoon once more, team. So we are still very few. We're about 23. I'm thinking. I think we may need to begin, and kindly let's mobilize our other colleagues to join. Because we don't have much time, and we intend to dispense with this. Within the hour. We really don't want to keep you in this call. So once more, let me take the opportunity on behalf of the NASCOP team to welcome all of us into our monthly data use webinar. So today we'll be discussing about deduplication, of course, leveraging on the unique patient identifiers to track our clients who are receiving services in more than one facility, and how can we use the master patient index to be able to track them, follow them up, and of course identify those clients. And of course, we'll also be able to provide guidance on what then do we do once we've identified that one or two clients are receiving services in more than one facility. So we developed an SOP, and we'll be able to share with you. I know a few of us may have come across the SOP because it was a concerted effort. We had an ITT meeting, and we agreed to come up with the SOP. So in this meeting, we'll also be able to share with you quickly the content of that SOP. We'll also be able to share with you some analysis that we've been able to do jointly between NASCOP and the Palladium team to help us just understand the magnitude of those clients who are receiving services in more than one facility, and exactly what do we need to do. So at this point, I want to welcome a few of our colleagues who are in this call. I think I've seen Kate Mbaire, I've seen Dr. Jonah, I've seen David Kimosop. I don't know whether we have anyone from CPC, so probably maybe as we wait for our other colleagues, we can probably just hear some opening remarks from our colleagues who are in here. Apologies from Dr. Lily. She's engaged, so she may not be able to join us in this call, but of course we have our blessings to go ahead. So allow me to request. I don't know that there's anyone from USAID in the call. I think I've seen Kimosop. I don't know. Do we have anyone else from SI Kimosop, or you can probably just speak on behalf of USAID as we begin? David.
Good afternoon. Confirm you can hear me.
Loud and clear. Go ahead.
Thank you, Franklin. I want to take this opportunity to maybe introduce myself. My name is David Kimosop, working with USAID as a deputy team lead for pediatrics and PMDCT. And I want to go straight to saying that thank you, Songkok, and I want to appreciate NASCOP team, one for setting up these learning forums, because I know we've been having a lot of engagements at county, at national level, even during work planning, but we really get time to see what our data speaks to us and to address some of the concerns that are usually raised during field visits and also from the specific health facilities. And I'm glad such forums will be used to address some of those concerns. And that means, therefore, that we will be very open and candid to share our feedback, our experience, and we look forward to more quality data that can be used for decision-making and programming. I look forward to an engaging session with everyone who is actively attending this meeting and making sure that some of the concerns that we've raised can be addressed. With that, I want to maybe hand over to the next person and look forward to learning. Thank you, Songkok.
Thank you very much, David, and thank you for getting time to with us this afternoon. Dr. Jonah Maswai from DOD, you can say hi to the team and a few remarks.
Yeah, thank you very much, Frank, and good afternoon to the team. It's a great opportunity to be here, and I really want to appreciate the team for organizing this. And I would wish at this point to welcome my SI colleague, that is Dr. Gonza, to make a few technical remarks about the meeting. Otherwise, thank you so much.
Thank you. Gonza?
Thank you, Dr. Masai. Yes, thank you, Frank, for giving us this opportunity. Also, just to start by thanking NASCOP for organizing this. I know we've done this for a few months now, every month. We recognize this is very critical. We know PMTT is one of those pieces that is in focus as we move forward to epidemic control. So this meeting is very important because we get to know where the gaps are so that we are able to intervene together with the counties down the side. So we are really happy to participate in this as DoD and looking forward to good engagement. Thank you.
Thank you. Thank you, Dr. Gonza, for your remarks. Before I call upon Kate Meira from PCO, I don't know whether we have anyone from CDC. I was just running through the list. I couldn't see Dr. Kimanga. I don't know whether Daniel Mahangi is in or anyone from CDC. Maybe you can just make a few remarks and say hi to the team. Anyone from CDC? Meanwhile, kindly let's mobilize our other colleagues to join. I can see the numbers are growing, and this is very recommendable. So let's just continue reaching out as we plan to begin. Maybe CDC team will join us later. So before I call Kate, I don't know whether Dr. Jacob also managed to join. Let me just check. Sorry. Okay. Jacob hasn't joined. Diana, I don't know whether you're in the call. Diana from Palladium. Okay. All right. So, Kate, we can probably speak on behalf of the other team members who haven't spoken.
Thank you, Franklin. Sorry, Franklin. Thank you, Franklin. And we will mobilize the PEPFAR team shortly. I've already sent them a message. For me, it's to thank everyone, to thank you, Franklin, and everyone who is leading this process and everyone who has taken the time to attend. I think where we are moving, we have so much data, and really, if we don't use it, then we will not figure out what the quality issues are. And another thing that I appreciate is that as we move towards, virtual meetings, I think something positive happened during COVID. We didn't know that we could hold such important meetings virtually, and we've been able to do a lot. So Franklin, thanks for your leadership. From the PEPFAR office, I say I'm interested to learn. I'm excited about this data use meetings. Thank you for this initiative from NASCOP. And let's keep moving together towards, continuous and really strengthened use of our data, because where we are with the HIV program, we are a mature program. Now what is left of us is to figure out, to use the data and to figure out best practices and how other countries can learn from us. So other than that, I want to sincerely thank everyone for attending the meeting, and especially you, Franklin, and team for the leadership. Franklin, I'm just following up with CDC. I'll give you feedback shortly. Over.
Thank you, Kate. Thank you, Kate. Thanks, and thank you very much for your remark. I also want to recognize the presence of the county teams. So I think I've seen Zaituni, Casco, I've seen Mike, CHRIO from Kakamega. So maybe Mike, on behalf of the CHRIOs, you can say a word and say hi to the team. Then Zane, you can also speak on behalf of the Cascos. Mike Ruto, CHRIO Kakamega, over to you. Okay. Maybe Mike is struggling with the mic. Any other CHRI in the house? I'm just trying to run through the list, see whether Maybe meanwhile, Zaituni, if you can hear me. Zaituni Hamid, Casco, Mombasa, if you can hear me. I hope the rest of the team members can hear me. Maybe we'll give them an opportunity later. Probably they could be having network issues. So at this point, I want to welcome some of our colleagues who will be presenting, will be sharing with us the slide deck and of course the demo. So first in line will be Paul Tusi from Palladium, who will take us the first part, which is basically some sort of an introduction to the work that has been done. And then Anne Kiwara will share with us the magnitude in terms of the clients. Those clients were receiving services in the multiple sites, just like I already alluded to. And then Lilian Taligola will take us through the process of deduplication. So in instances where you realize that you have maybe 2-3 clients in your facility, then what are you supposed to do? And of course, we'll also round that with a demo from Kevin Lanyo, who will take us through the P survey. And basically that will be on documenting the reasons as to why this particular individual is receiving services from one facility, and what are the corrective actions that we need to take. Because remember, P survey comes in handy, especially in collecting variables or data that we normally don't collect from our routine data collection tools at the facility level. So as a program, I think it would be nice to just understand what could be the reason as to why this client is receiving services, same services in more than one facility, in 3 facilities, for instance. So yeah, so Kevin will also be able to just take us through that that particular bit. Then finally, we will be able to just look at what are our next steps in terms of taking this up in our facilities. So at this point, allow me to welcome Paul to take us through the first part of the presentation. Paul, over to you. Once you're done, Paul, you can usher in Anne and Kiwara, who will take us through the magnitude of the clients. So, Paul, over to you.
Thank you very much, Songkok. Just give me a second to share my screen.
Yeah, Zaitun, yes, I've seen your message. You were struggling with your mic. I'm hoping at the end you'll be able to sort it out so that we can give an opportunity to speak on behalf of Cascos. And also Mike Ruto will also give you an opportunity at the end of our session. Thank you. Over to you, Paul.
Okay, thank you. Good afternoon, everyone. My name is Paul Ntusi. I'm a software developer from the National Data Warehouse team. I hope that my presentation is visible.
Yes, it is. Proceed.
Okay, thank you. So I think we'll just start with an outline of what we intend to present today. Maybe the first on the list is an introduction to our MPI, which is a Master Patient Index. And then I'm the one who will be taking you through this. Then there is the magnitude of clients on RT in multiple facilities, which I believe Anne Kiwara will take us through. Then we have the process of deduplicating patients on RT in multiple facilities. And then we're also going to look at documentation on the reasons and corrective actions for duplicate clients using P survey. That is, I believe Kevin Lanyo will take us through this. Then we'll have our call to action, I believe, which will have Songok take us through. So maybe just a brief background on the whole issue of deduplication. I think what we notice is that we have unique identification for clients that is within a national data warehouse being fairly vital. And we've seen that this is essentially key as we get to the point where we want to ramp up on individual level data, that is reporting on individual level data. Enabled to do this, we've had multiple attempts at deduplication. So that is both at the facility and at the National Data Warehouse. And yeah, with the aim of us being able to track these clients across different facilities. So different attempts have been made using probabilistic matching in the past, but we'll be able to look at the method that we've been able to settle on, that is with the support of the Ministry of Health and NASCOP. So the method that we're using currently is actually deterministic matching, where we make use of the national ID with backing from the civil registry to accurately match records belonging to different clients across multiple facilities. So we're also going to look at how we've been able to use the MPI that is in the National Data Warehouse to actually implement this. So what we usually have is that we have UPI being issued at the facility, that is by the client registry. And yeah, where we have, yes, we have UPI being issued by the client registry at the facility level. And then we have these patient records or client records being uploaded to the National Data Warehouse, and we're able to use them to deduplicate these datasets. This deduplicated data is also later on imported into our master patient index. And the main reason for this is that the master patient index allows us to expose these duplicated datasets safely to facilities where they can be able to action on these duplicate records and come up with the resolutions. Later on in the presentation, we'll be able to look at some of these resolution options that we're able to develop in collaboration with the NASCOP. And yeah, as you can see, like this is implementing the MPI has been very key for us, mostly because of three main reasons. Number one, the providence of a two-way communication between the National Data Warehouse and the EMR, which is currently being used to communicate the deduplication reports. This is also going to allow us to have this resolution action being sent from the facility all the way to the EMR. And then another key thing is that the MPI allows us to safeguard the client demographic data. So we can quickly look at the history of deduplication within the program. So we had initially the client PKV, which was generated at the site, and it is a concatenation of the client's sex, phonetic names, and year of birth. So this one was used to deduplicate clients at the facility level using DWAPI, which is our data warehouse client tool that resides in the facility together with the EMR. From this, the next step in the evolution was the use of the CCC number, which is a service number that is provided by the facility, and the client is required to move with this number as they seek services from different facilities. This did have its shortcomings, and as such, that is where we ended up having now the UPI, which adds on to the CCC number in that it allows for identification of clients across facilities. And this one now has also the backing of the civil registry, allowing us to actually verify that the patient demographics, things like their names, age of birth, are actually accurate. And this one is implemented using the Ministry of Health client registry. And on top of this now, in terms of with the new developments, we are now moving to the client registry that is also linked to the SHA. So I think we mentioned that we have an MPI that we have deployed within our national data warehouse. And the main reasons that these are going to be some use cases that we're able to find for deploying this. Number one is to act as a central store for the client records that we receive from facilities and other sources. You find that it allows us to ideally hold all the data from the different program areas in one central location. It also allows us to, the MPI itself has an API that allows us to have communication with other health information systems. And now this allows us to offer the matching outputs back to the facilities and also receive advice from the facilities on how to, on resolutions that have been made on the duplicate records. We've also been able to use the the MPI to try and bridge the gap between 90 to 100 gap in the verification process, where we link client records that don't have UPI to records that have UPI in other sites, with the intention of accelerating UPI issuance to those client records. And then lastly, we also found a use case where we use the MPI to do data quality assurance on these verified clients, where we are able to look at records that have been linked using UPI and then see if there's any different client demographics. If these demographics are found, these issues, if there's conflicting demographics, this issue is again sent to the facilities and they can be able to correct the demographics at the facility level. Here we can look maybe at one of the issues where we can see where UPI would be quite vital. In this particular case, we can see that you have 3 client records distributed across 3 different facilities. And we can see that without UPI, this would have been treated as three unique clients. But with UPI issued to this client, you can be able to see that the 3 records would ideally now share the same UPI, and you would have the 3 records being linked. Now, once we have this being done, I think we mentioned that these records are sent together with the hash2p to the national data warehouse. And from there on, there's the need to cascade this information back to the facility so that they can actually be able to action on these duplicate records. And for this, we have now the MPI providing the output. Here's an example of the matching output that is provided by the MPI to the facilities that is within Kenya EMR. So we find that the EMR is able to pull a line list of clients, and this data is the line list that is every single client as a list of facilities where they are able to, where they are currently receiving treatment from. So you're able to see the client, their details, and the active facilities. And then now after this, the clinician is able to action on this data. There are some workflows or an SOP that developed that shows the possible resolution options that can be carried out on these client records. I think from here, I will hand it over to Ann Kiwara, who can take us through the magnitude of client sonority in multiple facilities. Thank you.
Thank you, Paul, and greetings, everyone. So in this section, we will take a closer look at the scale of duplicate ART patients across facilities in Kenya. Next slide. And thank you. For this, we used the NUPI issued to ART patients as of July 2024. And as we've seen above, from the previous slides, we have seen the deduplication use case, and we define that as multiple interactions where we have clients receiving treatment in different facilities at the same time, and that's appearing as part of TX card in each of those facilities. We defined silent transfers as cases where clients are being termed as IIT in one facility, yet they are active in another facility. And for those ones, their ART initiation date is not in there between when they were termed as IIT and when they made their clinical visit in the different facilities. Then for those ones who presented as new patients with their ART initiation date being between those 2 points, we define them as IIT cases posing as new clients. We can go to the next slide. So as of July 2024, the NUPI uptake among clients on ART was at 90%, but slightly lower among PMTCT clients, and especially the new ones where the uptake was as at 56%. And breaking this by county, next slide. We see that Nyeri County is taking lead with a coverage of around 96.6% among clients on ART, and the same county has 91% among PMTCT clients. And we have ordered this from the highest to the lowest. We can go to the next slide. So we see Turkana is struggling at around 67% overall, and also has the lowest uptake for PMTCT clients, that is at around 64.6%. Next slide. And breaking the same by partner, you see that Mkomani Clinic Society is ranking at the top with a coverage of 98% among all the active clients on ART and 94% among the PMTCT clients. And can have a look at the proportions by partners. The next slide. We see that USAID Imarisha Jamii is ranking at the bottom with a coverage of 69% for the overall numbers and around 65.9% for the PMTCT clients. We went further to disaggregate this by age and gender to see whether we have a significant difference in the uptake. We can go to the next slide. And for gender, we see that there is no apparent difference between the females and the males. Both are at around 90%. But when we look at age, we see that children and AYP have a lower uptake of OP, and this is possibly due to the missing birth certificates. Since we know that the OP is given based on the national identification, and these are the children who have no IDs. And we can go to the next slide. So we now move to the deduplication using the NUPIs that have been issued to these ART clients. And we have seen that as at July 2024, among all the active clients on treatment, 90% of them have a NUPI. And among these, we were able to find that 10,897 distinct clients were active in multiple facilities, and they were appearing in 1,825 facilities, which means that on average, 10,895 clients are receiving ART in 2 or more facilities, and that's a total of 22,655 multiple interactions. So without NUPI, this exaggerates the TX card number by around 11,758, although 3/4 of these were implausible, since they appear to have the same NUPI, but they differ in characteristics such as age and gender. And this happens when the person keying these details uses other numbers besides the national identification number, and it leads to clients having NUPIs that are not reflective of their NUPI, like their unique identifiers, and thus you find that we had 17,352 interactions, which were implausible, meaning they had the same NUPI, but they share NUPI, but their age or gender differs. And then we had another 4,793, which transferred from one facility to another without informing the primary facility, and thus being termed as IIT, while they are active in this other facility. And we had other 1,097 who presented as new clients in one facility, and they are termed as the IIT in the primary facility. And when we break this by county, next slide, we see that Kajiado is ranking at the top with for multiple interactions. It has the highest proportion of multiple interactions among those issued with Anupi. That is at 8%, and 95 of them are implausible. On the other hand, Narok and Vihiga are leading with the highest proportion of active clients who are silent transfers. And then we have Bomet having the highest proportion of the IIT cases who pose as new clients in this other facility. Next slide. Next slide. Thank you. So when we look at the same disaggregation by partner, we see that Wezesha Afya is ranking at the top with the highest proportion of multiple interactions among those issued with Anupi. And it also had the highest proportion of the silent transfers, but none for the IIT cases posing as new clients. But we have LVCT Prison having taking the lead with the highest proportion of IIT cases posing as new. So in summary, we see that NUPI is instrumental in the deduplication efforts, and we all know the implication of this in the efficiency and quality of healthcare delivery. At this point, I will invite my colleague Lillian to take us through the deduplication process at the facility level. Thank you.
Thanks, Anne, and good afternoon, everyone. My name is Lillian, and I'm going to be taking you through the deduplication process at the facility level. Paul, maybe you can scroll down. So what I'm going to be talking about is just a breakdown of the standard operation procedure that was developed by a consortium of MOH, NASCOP, PEPFAR Partners, and Palladium. So we basically broke down the steps into three. So the first step was on preparation. The second step was on talking to the client. And the third step is to implement the deduplication action on the reasons given. So for preparation, it's basically just generating the report that my colleague Paul has shared earlier in the presentation. So the report will be availed in the EMR. Then the healthcare worker will be able to identify the duplicate patients, then plan a duplication action based on the appointment dates. So after identifying the duplicates in the duplicates report, then the second step is for the healthcare provider to engage the client just to find out if there are true duplicates in different facilities. Then, of course, document the findings. We came up with 3 different use cases that could result into the duplication. So number 1 was probably a wrong ID was used to issue NUPI. Number 2 was probably the distinct client on ART is on multiple facilities and is willing to choose one facility and continue with their medication. And the third use case was the client is a distinct client on ART in multiple facilities, but is not willing to continue in ART in one facility. Next slide, please. So the third process is on implementing the duplication action. So in this, like we had identified in the previous slide, the 3, sorry, Paul, just go to the previous slide. we had identified the 3 use cases. The first one was wrong ID used for NUPI issuance. So the client will, the healthcare provider will document the error. Then they will request the client to bring the correct national insurance identification. Then something to note is that the UPI will not change until we move to the new client registry. So for the second use case, the one that we had talked about, the distinct client willing to select one facility. So the healthcare provider will negotiate with the client to agree and select a particular facility that suits them. Communicate to the rest of the facilities to align on the deduplication action, then care end this particular patient in the non-selected facilities. Then, of course, documenting deduplication as the reason for care ending. Then for the third use case, which is a distinct client not willing to select one facility. For this case, then it will be the healthcare provider providing an ongoing support, counseling to the client, inform other facilities of the patient's status, and continue monitoring as you document the deduplication process. Next slide, please. So Palladium has made 2 technological enhancements to support this. So for facilities to be able to use this feature, they need to upgrade to the new 3.x. And some of the features that we have enhanced would include the automated deduplication report that is sent from the National Data Warehouse to the Kenya EMR. Then, of course, we have also enhanced the EMR to add an option, receiving ART in multiple facility as a care ending reason. Then we've also went ahead to develop a P-survey. This will be used to collect the reasons a client is on ART in multiple facility and document the same for corrective action. So as you can see on the screenshot on the right, this basically shows us the EMR has added the receiving ART in multiple facilities as one of the reasons for care ending a client. So at this juncture, I think I'm going to invite my colleague, Kevin Lanyo, who will be taking us through the P-survey on how to access the P-survey, administer the same, and access the P-survey results. Thanks. Over to you, Lanyo.
Thanks, Lillian. So I'm going to take us through the P-survey. I'll be assisted by my colleague, Ogutu Victor, who's logging in, having a bit of challenges with my Android device. So as he's logging in, I'll just guide us through the P-survey on the web app. Quickly check the. So kindly help me share, Songok. Paul, you can end your share. Thanks.
Sorry, Kevin. Are you able to tell? Sorry.
Yes, I'm able to.
Okay.
So as my colleague is logging in, I'll just take us quickly through the P-survey that we created on the web application, and then we'll be able to look at what we've done on the mobile app. So basically, we have a set of 15 questions. Some we will be skipped, but these are the identifiers we're tracking, looking at the patient's unique identifier, their date of birth, their gender, their primary or current facility, also the secondary facility name or names, if there are many, why they moved, in question number 6, and if they moved, whether it was intentional, so that's an open-ended question, will be filling. Then if there are any other reasons, we also will be collecting that information. What action has been taken to resolve the duplicates? And number 8, whether the issue of multiple fertility enrollment has been resolved. If yes, provide the resolution details. If no, you provide the challenges. And if there are any suggestions for future improvement, you also provide them and any feedback. So those are the questions that we'll be tracking. Then now I'll move to the mobile application in the hope that my colleague Ogutu has joined in. Let's share with him the link. Okay. I'll just stop the share and give him 2 minutes to quickly join in. Apologies for this. I just realized when I'm about to present that there's been a change on the live server, but we're going to resolve soon. So I'll just send it back to Songok, maybe as we wait for Gutu to join in so that we don't keep the meeting held up for too long. Over to you, Songok.
Yeah, thanks, Kevin. I just wanted to make an inquiry whether you're still having trouble, but yeah, thanks. So maybe at this point, as Kevin and Ogutu are sorting out the technological issues they are facing, maybe I can open it up for any questions regarding the process, the deduplication process, and basically probably would maybe if there are any parts that are not clear and you want to seek for further clarifications on the same, maybe we can take a few minutes to take those questions as we wait for Kevin and Ogutu. I'm just looking out whether there is I'm not seeing any hand up. So if you have a question, you can kindly raise your hand. Okay, I'm not seeing any hand up, so and I'm also not seeing any questions on the chat. Did I see a hand up here? There's a hand. Okay. Yeah. So yeah, Peter, Joker, you can go ahead and ask your question as we wait for Kevin. Peter.
Good afternoon. Thank you, Songok. I just wanted to follow up on what Lillian has presented. She indicated that the deduplication report will be available. So I just wanted to understand where that report will be available. Will it be at the site level or will it be at the national data warehouse level? Because the deduplication will be probably happening for clients between facilities that are either supported by a partner or across other supported facilities by other partners. So I would want to understand how we'll be able to get that report. Thank you.
All right, thank you, Peter. Yeah, so maybe Lillian, you can probably respond to that. Meanwhile, so Peter is asking about the process of deduplication. Okay, not basically the process, but the report, because I think you mentioned clearly that the report will be generated from the National Data Warehouse, but that will be sent back to the facility. So probably maybe you can speak more to that for better understanding. Lillian?
So thanks, Njoka, for your question. So the report will be sent from the National Data Warehouse, since this is the repository for all the data from the different facilities. So this will be matched in the National Data Warehouse and shared back by the specific to the specific facility, Kenya EMR. So you'll just be able to access it in the report section as the rest of the reports.
Thank you, Peter. I hope that is good enough.
Okay, we'll wait for that.
All right, right. Thanks. We'll still organize for more sensitizations on the same, just to break that down and even just take you through how to be able to access that that particular report. Kevin, I don't know whether you're ready now. I'm not seeing any questions on the chat, and I'm not seeing any other hand up.
Yeah, Ubuntu was managed during the meeting. He's sharing his screen, then we can go through the button.
Good. Yeah, I think I've seen him. So
We can't see your screen, Ogutu. Kindly share.
Oguto, we can't see your screen currently. Are you having trouble? Victor, kindly let us know if you are in trouble, please.
He says he can't unmute.
Okay, sorry, Kevin. Let me just reshare again.
Okay, thanks, so good. Okay, I think we're having challenges with the live server. We can propose to skip the demo for today. Over.
Okay. Apologies for that. I think that would be nice to just go through the demo. But yeah, we understand technology at times can let you down the last minute. So on behalf of Kevin and Victor, let me again just apologize on your behalf. So thanks. So I think we can then probably just because we are exactly with that exactly 3 and this. But before we do, I know we only have one question and we've already responded to that. So I can quickly take you through what our next steps are. And I want you to request, I don't know whether it was Paul, you can share your screen so that I can just quickly go through our next steps. Also, Lillian? Oh, sorry, Paul here. Just go ahead. All right. So so this is what we are asking the county teams and the service delivery partners. I think Lillian mentioned quite clearly that the announcements that have been made in terms of technology is available on 3.x. So that clearly means that all for you to be able to access this enhancement, then you need to ensure that or for you to be able to access the deduplication, then it means you need to update your or migrate to 3.x. We will share our documents or PDF documents. Let me just put it that because we just move to PDF so that we don't probably just make alterations. So we'll share. I'll be able to share an SOP in one, clearly indicating the steps as mentioned, and hopefully we should be able to take or make use of that SOP to sensitize facilities on how to access the deduplication report from the EMR. And of course, the expectation is that we should be able to implement whatever content in that particular SOP, which it clearly indicates how to identify duplicate or clients or receiving services in more than one facility. How you will be able to access that particular report, and what are the next steps? Of course, reaching out to the client and agreeing, because you see, this is a client who's receiving services in more than one facility. So at some point, you need to probably just have some discussions on where do they feel comfortable in receiving services, because if they continue receiving services in more than one facility, then that will end up skewing our TX card. We are giving ourselves a timeline of 3 months, so hopefully we should have been able to clean our data and have what I would call one-to-one. And after that, we should be able to conduct monthly audits to ensure that we have complied and probably just to look at how effective the processes of deduplications are. Palladium being the technology partner here, of course, working closely with the other HIS partners, we should be able to then leverage on the National Data Warehouse to be able to continuously and routinely generate and disseminate monthly deduplication reports to all the stakeholders. This basically is to help us keep track and follow up on these particular clients in a targeted way, just clearly knowing who is where and what actions are we supposed to follow up on. And here we are calling upon all the teams, the county teams, the facility teams, the service delivery partners to work very closely to be able to clean this data. Of course, Palladium will also ensure that we should be able to progressively capture the duplicates identified, and those duplicates that have been identified should be resolved at any one given time. So that's basically what we are requesting all the teams to be able to follow up on. Of course, we will have more interactions virtually in situations where you are able to probably just do a physical visit to the facility. You can also be able to provide mentorship on the same and do a quick follow-up on the same. So I think, having said that, that marks the end of our meeting. I'm not sure whether there are any other questions. I'm not seeing any question on the chat, and I'm not seeing any hand up. So allow me to end, because it's 5 minutes to 5 minutes past 3. Sorry. So at this point, I know I had requested a few of our colleagues from the counties to speak on behalf of the county. Unfortunately, at that time, I think they had challenges. I don't know whether they're able to speak now before we end. Mike, we can start with Mike or any other CHRIO in the house, because I think I've seen a few of them were joined. Mike Ruto, CHRIO from Kakamega. I don't know if it's still in. Okay. Yeah, Mike is still in. I don't know, Mike, are you able to speak? Zaituni, are you able to speak now? I know you had a challenge with your mic. Maybe a word or two on behalf of the county team.
I thought.
Oh, yeah, Mike, go ahead.
Thank you for giving this opportunity. Yes, the question as to which is our next agenda, or what do you think as a what do we think as a county is our area of concern? Let me speak on behalf of Kakamega and perhaps other counties that may be having this experience. Well, in terms of managing the viral load from the EAD website, I think many of our facilities have issues, particularly in getting the real numbers, or the true numbers of those who are, let me put it like viral load results. One is tease out the duplication. Two, find out within the reporting period the exact numbers that one would want to generate or to have a report about. So that is one of the areas that have seen facilities and even some county teams struggling to get the reports or manage the EID website in general. Thank you, and back to you.
Thank you, Mike. I think we appreciate the challenges with the EID and viral load database. I think we will have time to be able to discuss and also just come up with a process of how to make some of the corrections that we do experience. And I think we agree that we need to ensure that we clean data in the EID and viral load database. I know Elvis Kiroi is in here, and we also have other colleagues from the lab, and I think we've had discussions in our previous meetings to just try to put our heads together and see. And one of the things that we've noticed is that the way we do document our identifiers, be it IDs or the CCP numbers, we keep changing the nomenclature, and that poses a very big problem in terms of matching even the records within the system. So sometimes we try using the MFM code, but that becomes a bit tricky because then that doesn't really help you to clean the data. So you still end up having some duplicates. And I think with the introduction of NOPI, I think we are looking at a situation where we'll also be able to use UPIs to track samples from the facility to the testing lab and back to the facility. So that's an issue that we are following up closely, Mike, and we should be able to come up with the resolution on the same. Zaituni, maybe on behalf of the Cascos, or I think I'd also seen Dr. Bob. So Zaituni, I don't know whether you can speak. Oh, Dr. Bob, Cascos here, if you can hear me, you can unmute, you can speak on behalf of the Cascos and close the meeting for us. Dr. Bob Awino. I think Zaituni has challenges. He's not been able to speak, but she can hear us. Dr. Bob, can you hear me?
Yes, Doc.
Yes, Doc.
Yes. Sorry.
Yes, Doc. I'd requested you just speak. Yeah, Zaituni is also unmuted. So Bob, you can go first, then Zaituni. So Bob, you can go first. I just wanted to say a few words on behalf of the Cascos as we close the meeting. and of course they are accountable.
Thank you, Songok and team, for the update. We'll try to do the way forward, our role as a county, try to show our facilities are EMR.3.x. So thank you so much. Thanks, Songok. That's what I can say for now. Unless maybe there is another Casco who has anything to say, and then I'll close it there. Thank you.
All right. Thank you. Thank you, Doc. Thank you. And thanks for finding time to also just join us in this call. As Zaituni is having challenges, apparently we can't hear her. She is unmuted, but we can't hear her. I think she has challenges, but I think we can close it at that. So thank you very much, team. I will be able to share the SOP, and I'll also be able to share with you the slide deck that we have presented to you today. Hopefully, we can also be able to share a more granular analysis to the facility level. I don't know whether that will allow, but I think I can discuss with the team and see whether we can do that, because that would play up in terms of follow-up. So having said that, allow me to say thank you very much on behalf of the NASCOP team. We really appreciate every one of you. Asanteni and bye. Thank you.